page when my second computer starts behaving itself properly. Okay, so any points on page 1? Page 2? Page 3?
Yeah.
So somebody got the hand up? No. Okay, so everyone's happy for me to sign the minutes, is that correct? Okay, I see people nodding, so that's agreed. So let's move on to the next item on the agenda, which is the reports on service changes. Now, asking our sort of participants, Dr. Mehta, who I know has to leave at 7:45, and Kerry.
Excuse me, Chair, I'm sorry to interrupt you. We've missed public participation on the agenda.
Oh, right, okay, sorry about that. So public participation, we have one speaker, I understand, who's Mr. Andy Walker, is that correct?
Yes, that's correct, and he's present.
Okay, so would you like to cue him so that he can speak, please?
Mr. Walker, can you unmute yourself? You can speak now.
Yeah, okay. My question is, Chair, do yourself or any of your fellow councillors agree with BHRUT's assertion that children's A&E is still a type 1 facility, bearing in mind that it hasn't got child inpatient beds?
Well, perhaps I can mute yourself, Andy, because I'm getting a bit of feedback. Okay, so I think I can probably answer on behalf of the committee. This is part of the report on service changes, which we're just about to consider. Obviously, local councillors would be very concerned about changes to children's services, particularly as we are the biggest borough in outer North East London and have a third more children than either of the two other boroughs in outer North East London. So I think we just have to wait and see what the NHS tell us in terms of their plans for children's services. But I think I can say with some certainty that any proposals to close our children's ward would be strongly resisted by the council. Do you have a supplementary question?
Yes.
Oh, I should say, Andy, I'm really sorry, but for some strange reason, you're appearing upside down on my screen. I don't think you could do anything about it now, but you might want to think about that for future presentations because it just looks so strange.
I'm just pleased to be able to turn the computer on, so anything else is beyond me, I'm afraid. My supplementary question is, do yourself or any of the councillors share my concerns that BHRUT is refusing to tell the 111 service that there is no longer inpatient facilities at King George, so they can't. It means that seriously ill children have to be transferred and they should be going straight to Queen's.
Well, I think that's something which attendees can enlighten us on in due course. But again, I would say that any reductions in children's services in Redbridge would obviously be a major concern to elected members and indeed others here in Redbridge. So thank you very much for your contribution. I'm now going to move on, and thank you, Gilly, for reminding me about public participation. So I'm now going to move on to the two papers we've got, one from the East London Health and Care Partnership, and the second one, which is a sort of schedule of changes. And I don't know how our attendees really want to handle this. I guess I saw the East London Health and Care Partnership as something that Kerry Jacob would probably present, and then the more detailed schedule, and thank you very much for that, was perhaps something Dr. Smith might talk to. But I'm a bit in your hands on this one, so let me know what you'd like to do.
Councillor Bennett, thank you. I mean, I'll just do a quick 5-minute introduction, really, because obviously there aren't any slides, so we'll just talk through. And then I'm going to hand over to my colleague, so to Dr. Mehta first, because as you say, he has to go just to update on the primary care changes, and then obviously Magda, Claire, and Bob in turn to sort of take you through their elements of the papers that we sent you. So I hope that's okay, and we will pick up your questions obviously at the end. So I don't intend to go through the detail of the paper. First of all, obviously, just to, I thought that might go down well. So first of all, just to thank, obviously, again, all staff from across health and care in the North East London system. It really was a sterling piece of work that they did and are continuing to do. And we're quite clear that we do owe it to them, not just to try and reset what we had before. We need to be more resilient going forward. So we need to make the changes that are good now so that we're stronger in the future. Excellent working, which again, I just want to formally acknowledge across health and local authority partners. There was some really, really good work. It built on previous good relationships, but definitely took us to another level. And we certainly thank our local authority colleagues for the support through the COVID response and now through the COVID recovery phase. You'll note from the paper that we sent you that we sort of took a four strand to our approach. We rapidly built capacity. We did everything we could to prevent infection. We developed a very flexible workforce, some of which will come up through the presentations, and we absolutely put patients first. So by looking at it through the patient lens, normal organisational boundaries were firmly put to one side so that we could focus on the important stuff. So as I say, I won't go through an awful lot of that. The workforce changes were very rapidly made, actually, and again, testament to their flexibility and their willingness to step up to whatever was needed. Our document does provide you some rationale for some of the changes, and also the assurance processes and sort of a summary of the movements and suspensions of services that were necessary to be taken at that point. And as I say, we hope that between myself and my colleagues, we'll be able to answer all of your questions. We are still flat out. It has to be said that restarting services is very, very difficult. What we're having to do at the moment is to continue to deal with existing COVID infections, be ready to deal with any surges in infections that come along, restart services safely and in an entirely different way because of the requirements around infection control and a greater reliance on virtual care to support that. And also obviously to manage the impact on the interruption to long-term condition management. And Dr. Netter will probably pick up some of that as he talks. So I'm not planning really to do more than that. I think probably you'd much rather hear from our provider colleagues to take you through. So perhaps if I can hand over to Dr. Netter in the first instance, just to sort of take you through some of the highlights of the primary care changes that were made.
Okay, that's really excellent. So Dr. Netter, the floor is yours.
Thank you very much, Kerry, and thank you, Councillor. Just to echo Kerry's message, really, it's been an unprecedented 3 or 4 months. We've never seen anything like this in our medical sort of training or previous to this. But I'm really pleased to report to the committee that actually, as far as primary care is concerned, we've adapted really well to the processes, and we've kind of, I feel, continued to deliver really high quality and safe practice. What happened 3 months ago was that we found ourselves in the midst of something terribly serious, which meant that we now have adopted a new method of working in terms of triaging all patients through video consultations and telephone consultations, but also not forgetting those vulnerable people that still require face-to-face consultations. That will always be the case. In each borough, we created successfully hot hubs where we focused on COVID care. In each practice, we've created hot and cold zones where we've tried to align clean and unclean areas. And we've noticed a lot of cross-practice working, which has worked really well. What I can also report is that there's been some excellent collaboration between primary and secondary care. And this, as you'll know, is always difficult to get right. But our colleagues at secondary care have really, really risen to a fantastic challenge and brought about changes to secondary care that have been now embedded as normal practice. We took on the care home challenges, and we've all seen the difficulties that care homes have been through over the last few months. We've set up remote working through care home ward rounds, virtual ward rounds, and we've started remote monitoring services for patients. And all along, we've got to remember that there's a real sort of possibility that in amongst all of this, there's a danger that we might miss serious illness, and mindful of the fact that we need to continue to provide care for our long-term conditions. As Kerry has highlighted, we are continuing to try to restart the sort of health system in terms of our long-term care management. But I'm really pleased to report that the 42 practices in Redbridge have really risen to the challenge. We have some regular communications with our practices. So really grateful. It's been a tough 3 months actually, and such sadness amongst people that have lost loved ones and lost friends and family. Thank you. I'll pass on to Magda.
Okay, thank you. Dr. Smith.
Thank you very much, Councillor Sandwich. I think we covered a lot of the acute sudden changes that happened in the hospitals at the last Scrutiny Committee. So I think that the paper that has been put through is really where we've been able to step services back up that had to be deferred, delayed, moved, etc. So in terms of cancer across the sector, a lot of our cancer work is continuing as it was last month, but we are starting to repatriate cancer work, particularly the cancer work that was going to the central London hubs. In terms of screening, bowel cancer screening has now restarted. We received notification of that formally this week because we don't run the screening programme, we deliver it. And cervical cancer screening is now stepping up again, which is not at full strength, but it's all gradually being repatriated, not just at EHRUT, but across Barts Health and the Homerton as well. In terms of our maternity services, most of the maternity services that were changed during the height of COVID are now being re-established. So, for example, our home births, from a safety perspective, were suspended for a short period of time. Those have now been reinstated. And we're also gradually returning, where necessary, face-to-face appointments, particularly for antenatal services. And in particular, I know that there will be a section of the population very concerned about the delays in fertility services. And I'm pleased to be able to report that we've re-established our fertility services from the 13th of July. We've now got able to get those back up and running for those women, particularly those women who are in that time frame that really need access. In terms of outpatient services, we're continuing to try to see as much, or see in a virtual sense, patients as much virtually as possible, but we are stepping up those face-to-face services where they are clinically deemed necessary and working through that with our clinical leads, and that is happening across the sector. The therapy services, a lot of us, our general therapy services moved to virtual appointments. I have to say I've personally been a subject of that, unfortunately, in the last couple of weeks, but actually it's providing a very efficient service. There was a suspension of the inpatient rehabilitation unit at King George's for our stroke services. The inpatient rehabilitation continued for our patients through our acute stroke unit, but we will be reopening our King George rehabilitation unit in collaboration with Nelft in one of the wards in the King George Hospital site. They're just doing some conversion of the ward to make it suitable for the patients, so I haven't got an absolute time frame, but it is part of our ward reconfigurations and is urgent on the agenda. In terms of our paediatric services, Andy Walker's already alluded to the closure of the paediatric inpatient unit. We are working through, absolutely mindful of the paediatric population in Redbridge, what the offer to children for Redbridge is going forwards, and we'll be sharing that with you as we're looking to step up services. But just to reassure you, we monitor on a daily basis the KGH King George attendance for paediatrics, which still remains extremely low, and the paediatric inpatient requirement for patients remains extremely low as well. That is monitored on a daily basis and is an area of high focus. In terms of planned surgery across North East London, we work very closely with Barts Health and the Homerton around re-establishing planned surgery and looking at prioritised patients. And all of our trusts are now re-establishing the most urgent planned surgery, but absolutely mindful of infection control practice and the national infection control guidance around good practice for patient safety. We are very, very mindful and discuss on a regular basis, which is almost daily, about those patients for whom the infection control requirements could put them at a disadvantage. So at the moment, for a planned operation or a day surgery operation, you have to self-isolate at home for 2 weeks, pre-surgery and post-surgery. Now, people who are self-employed, who need to work, who need to be out in the community, that is an extremely difficult thing for them to do. So we have escalated this concern that there's a potential inequality, and are totally focused on it and looking at those patients who are unable to attend for surgery. So it's a primary focus for us, because we are very concerned about those patients who feel they cannot attend for surgery on that basis. In terms of the urgent and emergency care, we presented previously about the increased capacity in critical care. That capacity still remains, although we have significantly lower numbers of patients in our critical care areas with proven COVID. We still have to separate the elective surgery operations who require intensive care from other patients who require intensive care, which means that all of our hospital sites have had to look at how we provide that service. It's more difficult for some than others. I'm pleased to say that we have a green COVID protected ITU at King George's for those elective pathways as we're setting those up, and we'll have that for Queen's Hospital, and Barts Health are looking at each of their sites, and the Homertons similarly, and we're in discussion with NHS London on a regular basis about how that critical care capacity can be most appropriately provided. In terms of activity, I can speak about the Queen's and King George's emergency attendance activity. I'm not familiar with Barts Health or the Homerton activity, but what I can say is that at both of our hospital sites, attendances, type 1 attendances, Mr. Walker alludes to, those are the attendances that are dealt by the emergency department as opposed to the urgent treatment centres. They're not at pre-COVID levels. Admissions at King George's are not at pre-COVID levels, but the admissions at Queen's are now moving towards pre-COVID levels. We are reinstating some of the good practice that we had around emergency care prior to COVID. We had established a frailty hub at the King George Hospital site, which was proving to be very successful in providing specialist urgent assessment of frail patients. And that will be opening again at King George's, I think, from Monday. And we're working through all of the urgent attendances. So whilst Anil is the GP CCG lead for BHR system, Jagan John is the CCG lead clinician for urgent care, and we're on a regular call with him. I have to say that the national profile of urgent and emergency care will change. There are pilots going on currently in Portsmouth around how to manage urgent and emergency care in a slightly more planned way. And we're having those conversations internally about how we can work with patients who need urgent care, but in a slightly more planned way rather than random attendances. But we're just working through that at the moment, and that's a piece of work that's North East London is leading on from a London perspective. I will leave the step up around community and mental health services. You have the paper that describes that, and I'm at the end of this happy to take any questions.
Okay, thank you. I just want to ask Dr. Mehta before he goes, given you've mentioned about the offer on paediatrics to residents, where local GPs stand on the inpatient service for children at King George.
So from primary care's point of view, paediatrics continues to be seen in primary care, and we have a close liaison, close working relationship with our paediatricians at the hospital. In fact, we've got hot clinics and urgent sort of contact points with our paediatricians. So from a primary care point of view, the typical pathway of a paediatric case will not have changed. Essentially, I mean, we would still be bringing in children to the practices and liaising, perhaps, I think, probably more rapidly with our paediatrician colleagues. And I think what this is highlighted is that the closer virtual way of working that we've unveiled means that we get more timely expert advice for paediatric cases, far better than I've ever felt in my last 24 years as a GP.
Sort of rather avoids the question though, doesn't it? Can I put you on the spot again and say, how do you feel about the inpatient service?
Well, let me reiterate that the inpatient service from a GP's point of view, I wouldn't say that has been affected adversely in any way. I still can use the inpatient service for my paediatric cases. So I'm not quite sure where that sort of level of concern has come from.
Okay, well, we won't pursue that now. But I just want to flag up that there is concern. Obviously, there will be concern amongst children and families, and there will be concerns amongst elected members. And it's part of a broader picture, isn't it, about services in Redbridge being closed to fund services in other boroughs.
Sure.
So obviously, as local councillors and representatives of people, we naturally have a very real concern about that. But we'll park that for the moment. And I know you've got to get off, so thank you so much for coming.
Well, thank you very much.
It's always a pleasure, Dr. Mehta. Thank you so much. So I just want to say now, in terms of managing the meeting, how we're going to handle this, because I'm conscious of the fact that not only are the documents quite complex that we received, but also in fairness, we're going to have a number of speakers. So what I'm planning to do now, subject to whatever Kerry wants to say, is to suggest that we perhaps have a pause now so that people can ask questions of Dr. Smith, okay, and of Kerry, and then I'm going to move on to Bart's Health and then to Nelft. Is that okay with members? And I sense that Kerry wants to say something.
No, I was actually going to suggest exactly what you suggested. So no, really happy, Councillor Zammit, that's fine, thank you. Okay,
well, that's great empathy, isn't it? Telepathy operates over the airwaves, doesn't it? Okay, so now it's any member got any questions for Dr. Smith or for Kerry Jacob? So the floor is yours. Stick your hands up using your hand up facility. Okay, let's just see what we've got. See any member? Julie, can you see any member?
Councillor Chowdhury? Yes, Chair, we have Councillor Brewer, Councillor Chowdhury, Councillor Islam.
Okay, so let's go with Councillor Islam first.
Okay. Thank you, Chair. One of my first questions to Dr. Smith is, I thank you for the lovely presentation, and obviously we appreciate your hard work. But one of the things I was really concerned is you're working in partnership with social care. And when we have people discharged in the community, because we don't want people to stay in hospital too long, and they're expected to be discharged in a very short space of time, that is working really well. But also there are large care packages, often either COVID related or not COVID related, but because we wanted people out in the community very quickly. And most of the time, local authorities are picking up care package. It is a very difficult question, but I'm just trying to say, how can we support both sides in terms of setting up support packages and looking into joint packages if possible? In some cases, there are clinical needs as well as social care needs, and often it's one or the other. Very rarely we would do joint funded packages, and that is time consuming, and at the moment we don't have that time, and we try to discharge people in the community very quickly to manage infection control. So any future guidance or any work already in place? Thank you.
Thank you very much. Absolutely. The challenge of discharging patients from hospital in a timely way with the right infrastructure around them when they then move into the community is really, really critical. I think the first thing to say is that we've actually deviated from the national guidance a little bit in terms of the COVID safety practice, in that we have an agreement locally that we will wait for the swab result of a patient being discharged into the community, so that we know if they're COVID positive or negative prior to discharge, if they need a care package or are transferring into a care home, where that is possible. The national guidance says that you don't need to do that. So we've slowed down our discharges a little bit because of that, which is putting a little pressure in the system internally, but that's fine. In terms of the process of working through appropriate care packages, actually, partly from COVID, but it builds on the work that we were doing previously. We have something called a red to green team, which works really, really closely with the local authorities around discharge of patients. And we've had people from local authorities, social care, sitting in the hospital alongside our red to green discharge team, working through those care packages. It's always going to be complex for people that the priority is to get people home wherever possible rather than into care homes. But working with social care to be able to do that is always a challenge. At the beginning of COVID, there was a national mandate that we had to discharge patients from hospital very rapidly. We've moved back from that quite a long way in terms of making much more planned discharges in collaboration with social care and with our community. So NELFT have had a significant role to play in all of this as well. So I think, to say in summary, basically we are sort of going over and above in terms of COVID safety on discharge. We are still working very closely with NELFT for those patients where it's not easy to get a rapid discharge from hospital into an appropriate care setting in home. And we are working with our social care partners, and there's regular conversation about doing that in an appropriate way. It's always a challenge. It was a challenge before COVID. It's still a challenge now.
Thank you, Dr. Smith. I was concerned about the funding element of it, and probably someone else can assist on that. But I know Mark is there, and I've noticed Kerry has also got her hands up. But it just also, it puts a dent on social care budgets, or pressure on council. But that was my second question, or second part of the question, about funding, level of funding contribution. Thank you.
So, I mean, yeah, Kerry, maybe you'll
Shall I? Yeah,
that would be helpful. Thank you, Kerry.
That's all right, Magda. We're into my so I'll pick this one up. So during the COVID response, and I'm not sure how much detail you would have had, it was agreed that we would, that the council would pool the money they would normally expect to spend on packages of care with health, and then health would just pay everything, so that the top up, the extra cost would be borne by health. So that's how we've been managing it through the COVID period. Obviously, there will be people post-COVID with ongoing care needs, and some of them really quite significant. And this is the work that we're now working through. We have something called a SOCG, which is a System Operational Command Group, but effectively that's where we're working together with our local authority colleagues to look at how can we do this in the longer term, in a better, more joined up way, and using money to the best effect. But certainly through the COVID response, the money that the councils were asked to put in for care packages was based on what you would normally have spent, I think, in the same period in the previous year, and the top up coming through from health, and that was a guarantee that was given. And we signed it, we put it through our BCF, our Better Care Fund, and that was all signed and done.
Chair, can I just ask one more very quick question?
Okay.
Sorry, just to add on is, as we're predicting possibly another outbreak, have we got any future plans? Because obviously that's quite imminent, and we may have to have cluster closures. Where would we stand on that? Thank you.
So should I? There's a general thing really just about the preparedness, surge resilience, as we're sort of calling it really, and every provider and the CCGs are working together with the local authority partners to make sure that all of our services can cope with the next surge and still continue to provide some business as usual services. I think it was this meeting Magda said last time, all of that learning that we had to do through the first phase has done. We sort of know what's going to have to be done now. So we will have much more time to do this. So the other piece that we are looking at, is the bit about the discharge. And we're working with NELS very closely to be able to discharge people who are COVID positive, not into a care home, and to try and protect the care homes far more. And certainly Adrian and Gladys and colleagues have been very clear that we need to put in different arrangements, and hence the Trust has already gone further than required to in the national guidance in terms of waiting for the swab result. And as I say, we are working rapidly to get this alternative in place ahead of the next surge, which we think will be around about November time.
Okay, well, that's a pretty chilling thought. I've also, the thought of us giving you our money has sort of raised the hairs on the back of my neck, but I guess
you haven't given it to us in Councillor Savage. You haven't given it to us. You've pulled a portion of your money for a portion of the year based on what you normally would have spent, so that we could then top up the extra spend in relation to care. I promise you, we're not taking it from you. We're just we're trying to help. It was a way of taking money out of the equation, so that when we looked to the packages of care and to place patients quickly, money didn't get in the way. It was just accepted we would top up the gap.
Okay, I wish I hadn't mentioned it now. But I'd like to move on to Councillor Mrs. Brewer.
Thank you, Chair. I just wanted to echo the tributes already rightly paid to the hard work of the NHS frontline staff throughout the pandemic, and also to say that I am a Redbridge councillor. I live in Redbridge, and I'm here to represent the interests of the people who voted for me and exercise my health scrutiny function appropriately. And when a service is changed for emergency reasons, the NHS body must notify the local authority immediately of the decision taken and the reason why no consultation has taken place. So why did this not occur in Redbridge is my question, and why did we have to find out about service closures from the local media? Very big concern. And can the local NHS assure us that they will in future comply with the law on service change and consultation? So I need to be firmly assured that our local residents are going to have full involvement in any of these changes, and I am extremely concerned about what happened. The closure of children's inpatient services in Redbridge, Clover Ward, was especially disappointing. Nothing that's been said this evening makes me feel any better about that or any more assured. In fact, I'm even more worried. Do the Trust and the CCG accept that it was wrong for them to close such a core service without notice and without communication with GPs, the local authority and other stakeholders? And can we please have firm assurance, not received it yet this evening, that the full level of paediatric care will be returned to and maintained at the King George site? Thank you.
Okay, so that's a real challenge for you, and I think probably Kerry should go on that first.
Yes, no, that's fine. Thank you, Councillor Zanet, and thank you, Councillor Brewer. So we were, and again, we did touch on this briefly last time, but perhaps a little bit more detail this time around. So obviously, when we were in a level 5 escalation for in the national pandemic, the changes do just need to be made because you are working at that pace. The hospital would not have coped if we had not been able to make the service changes that needed to be made, and we would not have been able to keep the patients safe and secure and to have done everything we needed to do around infection control. So the level 5 escalation does mean that providers can move at pace where they have to secure the safety of patients and to maintain service delivery. I think the point about the engagement now is a really important one, and that is one we do need to get right. So We don't really know exactly what we're going to need for probably another 18 months. COVID is here for a while. Even if a vaccine comes sometime next year, that will take time. So I don't think we can say anything is permanent at the moment, because we'll be dealing with waves of COVID. So no change can be seen as permanent at this point. The other thing I think is to be really clear. We need to understand what these mean for patients as well. So there's quite a lot of work that's being initiated at the moment to go out asking patients, what does this feel like? What do these service changes feel like to you? Can you still access them? Are we inadvertently excluding people because of digital poverty in some households, for example? So this is work that's underway. We are just about to commission a piece of work to make sure that we reach as many of our population as possible to ask these questions, because it may be that some of the changes we've made, we have to maintain something to maintain maybe infection control, but maybe we need to think about how we make things more accessible for people who perhaps can't do the digital virtual by default piece, for example. So we will do a lot of that sort of work over time. If there is a change that we feel needs to be permanent, we will absolutely, Councillor Brewer, I can give absolute assurance, we will go through the normal consultation processes. We understand that we have to, and we will do so. And likewise, we will engage. So sharing these service changes here at the moment is part of that engagement.
Okay, so I think logically the next person to speak should be Dr. Smith, if you've got anything to add to what Kerry's had to say.
I actually don't think I do. I think I would support everything that Kerry has said. Thank you.
Okay, that's good. So I'd now like to call on Gladys Xavier, Director of Public Health. Are you with us, Gladys?
I am, thank you, Chair.
And so what would your view be on paediatric services?
I think that's already been addressed, because we do engage closely with the CCGs and our colleagues, because we are responsible for the 0 to 19 and 0 to 25 service. So I think we are aware, because the population of the young people in Redbridge, so if you look at 0 to 4, it's actually 7.5% of the total population, which is higher than England and London. And similarly, the 0 to 19 as well. So the need is really there. So we are, through our 0 to 24 strategy group, that we do meet regularly. So we do make those, we're doing a children's needs assessment. And so we will be presenting those findings to the work that's being done across.
Okay, I just make a couple of points from the chair. Firstly, that if you look at what's happening in inner London, you'll see that the Homerton have re-established their children's service. It's a much smaller children's population than Redbridge. And I think one of the themes we're going to be developing as a council is the differentiation between inner London and outer London. So inner London doesn't matter about utilisation. They get their services restored straight away. In outer London, well, there's a question mark, isn't there? And I think it's behoves us as local representatives to make sure that there is fairness across North East London. And it doesn't look right to me that Homerton gets their children's services re-established very quickly and ours remains closed for an unknown period. But I want to return to Councillor Brewer to see if you've got any other additional points you want to make.
Thank you, Chair. To be honest, Chair, I haven't had an answer to my question. I really want to know when Clover Ward is going to be open. We are as Gladys has been commenting on, you know, we have a very young population, and we are a growing borough. Queens is a long way away. And I personally know, having had 4 children myself who have not enjoyed good health, of what it's like when you have an acutely ill baby and child and you have to get to the hospital very quickly. And I am very, very concerned about what has been basically taken away from our Redbridge residents. And I want Redbridge to have its inpatients paediatric ward reopened as soon as possible. And I want some assurance that that's going to happen. Thank you.
Before you answer, can I just make one other point and ask Kerry to come on this? Why has the Homerton been allowed to reopen their children's services and King George has not been reopened? Where's the equity in that? Where's the fairness?
I think that there is. It's quite hard to do a direct comparison. BHRUT is a hospital of 2 sites, feeding a much larger population and has a bigger infrastructure as well. Homerton obviously is a single site and is therefore a different beast really to BHRUT. Just to go back just to Councillor Brewer's comments. I think I did say that one of the things we need to do is to understand the demands and capacity going forward as we come out of COVID. We are not yet back into a steady state. We're a long way away from it. So it's quite hard to give a firm date. At the moment, if I remember correctly, Magda, please do correct me if I'm wrong, the activity is not yet a problem in the paediatric services. It's still not back anywhere near where it was pre-COVID. We need to understand where it's settled, I think, before we take any final decisions, and any final decisions will be engaged on and consulted on in the appropriate way.
I mean, I hate to come back to you on this, but it does seem to me it's a very straightforward comparison. You know, it's one rule for inner London and another one for outer London. And I don't think that's the sort of unfairness that we can tolerate in the longer term. And I would have thought from a strategic perspective, the huge imbalance of service between inner and outer London is something which the partnership is going to have to address. I mean, we have something like 3 times as many acute beds in inner London as we have in outer London. One A&E for about 300,000 people in inner London. And if you look at the BHR catchment area, then we have 2 at the moment A&Es for something approaching 1 million people by the time we've allowed for inflows from Essex. So I think we will be continuing to press you on what I would call fairness and equity. And I don't think that's so much an issue for Dr. Smith. You know, BHR can do what they can within their very limited resources and so on. But I think it's a real issue for the partnership. And I think one of the things which I'm very concerned about is how this imbalance is going to be addressed strategically. And what we're seeing here is just a symptom of that imbalance. One rule for the Homerton and Hackney, a totally different rule for outer North East London and Redbridge. I'm going to leave it there, but I promise you we will be revisiting this. Now, Councillor Brewer, did you have any additional points?
Not at this stage, Chair. Thank you.
So, very good. Thank you so much. And I'm going to move on to Councillor Ms. Chowdhury.
Thank you, Chair. I've got a few questions. And would you prefer for me to ask them all in one go or one at a time?
Best to ask them all first.
Okay, perfect. My first question is about the finding from the report mentioned on page 11. It says that for many BAME groups, there is a lack of trust of NHS services. So I want to ask, why is there a lack of trust and what will be done to mitigate this? Furthermore, page 11 also highlights the long-standing inequalities faced by BAME communities. The report by Public Health England has addressed this, but not actually highlighted the why factor as to why BAME communities are at a higher risk. I therefore think that more needs to be done to tackle health inequalities. A more proactive approach needs to be taken in order to ensure that BAME communities are not disadvantaged. So my question is, if there is a second wave, what action will be taken to ensure that BAME communities are not facing inequalities? My next question is about building capacity, which was mentioned in the presentation. Limited capacity and not enough beds has been an issue for quite a while. So on a local level, how much of an increase will there be in critical care capacity? And my final question is, when we reach a new kind of normal, I think another issue that needs to be tackled is appointment waiting times, which can be very, very long. Is this something that can be looked at, because it is very important and people should not be subject to waiting very long periods of time just to see their GP?
Okay, well, that's wow, what a list. I'm going to suggest I'm going to suggest to the respondents that you make very short answers to those questions. I mean, the BAME one in particular is a very big and very hot issue. We still don't really have enough data to totally be clear about the relationship between ethnicity and mortality, for example. But I don't want to answer the question for you. So my plan is to let Kerry go first and then come back to Dr. Smith, if that's okay.
Yeah, perfect. Okay. So if I take the inequality, so there's two strands to answer on. There's the near time surge piece, and then there's the longer term, because actually it was the inequalities that have been in our area for a long time that drove some of that differential. So there is a North East London, one of our recovery programmes being led by Public Health, is a Public Health and Inequalities work stream. And that's looking to identify 3 key areas where, working at a North East London level, we feel we can really start to tackle some of the inequalities. Some of the work that we're doing locally, both at a North East London level, but also at the borough and the BHR level, is around anchor organisations, for example, and using actually the size of the public sector, if you like, in this area to try and address some of those economic inequalities that actually do also then impact on people's poverty, obviously, and their susceptibility to disease and long-term conditions, etc., etc. So that's some work that's going on. And the other thing that we're requiring of each and every recovery work stream is that they do say what are they doing in their work stream to address inequalities as well. So if I give you a near-time example for primary care, because that will address your next surge. So the people who are most likely, who are most at risk from COVID, are also the people who are most at risk from seasonal flu. So we know that. And we also know that traditionally our flu vaccination rates are quite low. So one of the things in the primary care space to address inequalities is to make sure that we have vaccinated the maximum number of people possible this year to try and protect them from flu, which will make them more susceptible to COVID, etc., etc., etc. So that's a piece of work we're doing. We are over-ordering vaccine. The general practices are being supported to look at how they can work together to vaccinate more people while still maintaining social distance. And there's a huge amount of work that's being driven at North East London and at a local borough level to support this. I won't go into the detail now, but there are detailed reports that we're very happy to share the inequalities work in more detail at a later date, councillors, and if that's helpful. There is a lot that we plan to do and are doing.
Okay. So I think just to come in here, I think there's something for the local authority to do as well. Inequalities, as we know from the Marmot report, are not so much about health, they're more about socio-economic issues, and that's our bag rather more than yours. But I think
we are working together, councillors, and we are working together on this. So exactly. As I say, it's a public health-led North East London group, and there's representatives from this borough there as well.
So we need to find a way of bringing those very important issues back. And I think it would be good if we could agree with the Director of Public Health and yourself, a timetable perhaps for doing that, because I don't want to take the issue too early. As I say, I think we need more data, particularly around the COVID-19 situation. We have a lot of very helpful data already about things like life expectancy on a ward-based level. But if we could, outside the meeting, perhaps agree a way in which we could come back to this where we perhaps got a fuller picture. And Dr. Smith, was there anything you wanted to add to Councillor Chowdhury's questions?
Just specifically about critical care. So we absolutely have got planned in the appropriate critical care capacity for our population. We have bids in with NHS London to ensure that that is enabled for the future, and that we're able to respond to future COVID surges. I think in terms of appointment waiting times, I mean, your specific reference was to primary care appointment waiting times. Certainly this is, from a secondary care perspective, this is all part of the elective restart programme. So whilst we absolutely recognise that, particularly with COVID, the appointment waiting times for secondary care have become unacceptable, this is part of the elective restart programme. And I think Anil earlier referred to all of the work that's being done in primary care to enable access to primary care to improve.
Okay, well, thank you for that, and thank you for answering all those questions. I do want to move on now to Claire Burton from Barts Health to say a little bit about Whipps Cross, perhaps. Are you with us still?
I am indeed. I am indeed.
Bring us up to date. What's happening at Whipps?
there are lots of parallels with the work, obviously, with BHRUT. And so I will do my best not to repeat, but I feel that there are assurances that would be really helpful. We are well into what's being described as our phase 2 planning, which is getting ourselves back into reinstating our services. There are plans to reinstate all the services on site. So everything that we were doing before, we're expecting to have on site. We are starting with caution as described by BHRUT. So the new infection control regimes, how a patient enters and exits the buildings, how somebody enters the emergency department and flows through there into the body of the hospital to outpatients. All of that is completely required the redesign. And as you can imagine, social distancing in a Victorian building, and once again, no different from BHRUT with its multitude of buildings, is just something we are going to have to work through. And each time we get an area that meets the criteria that means that it's safe, then we open another door. So in terms of, if I work from the front to the back door, that might be a logical way of doing this. And I appreciate you've got paperwork in front of you. So from the emergency care pathways, we're seeing about 70% of the activity that we were pre-COVID. But I think as described for one of your hospitals, or I think by your CCG, our admission rates are now at pre-COVID. So whilst the attendances are down, we're finding that those patients that are referred are slightly more likely to be admitted. We've had amazing support from our community colleagues and primary care who have done an exceptional job gatekeeping, and that will influence the type of patients who come to ED. So I don't think it's a huge surprise that perhaps we're admitting slightly more proportionally than we were. Our COVID and non-COVID areas, at its peak, we had all of our beds were COVID, with the support of, once again, of primary care pulling anybody who didn't have COVID out of the hospital. So at its peak, 250 beds were dedicated to COVID patients. I'm pleased to share that we're down to 1 surgical and 1 medical ward that's dedicated to looking after patients that are COVID positive. And today we've got a count of 6. For the last 2 weeks, it's only been 6 to 8 patients. So it's a positive flat line from where we've been. The remaining wards that are open are non-COVID wards, the dominant patients, and we have a normal mix of both surgical and medical patients. Our elderly population we are seeing a large number of admissions, and through our front door, I'm pleased to say that just last week, our frailty unit was opened, and our frailty services, they re-engineered themselves to do much more outreach and make themselves as accessible as possible to primary care. That worked well, and that is still in place. But it's great to have the frailty unit open because, of course, that's the short stay, trying to get people in and out of the hospital as short a time as possible. If I move on from the non-elective, the important, the cancer component, you'll have read in our brief that, and as described by BHRUT, we utilise the hubs to ensure that those patients within active treatments maintain treatments, and that new patients and or any patients on the list that consultants were concerned about could be escalated through into the cancer hubs. Our St Bart's as our cancer hub for us is rapidly getting back to normal working within this new era of screening for COVID. So from a surgical perspective, we had a go live challenge for our elective programme to go live on the 8th of June, and we're very pleased that our teams have been able to do that. The services to go through first were colorectal, general surgery, ENT, gynae, ophthalmology, urology, and maxillofacial. So a good tranche of patients were identified. Every patient on our waiting list has been medically reviewed and prioritised, and those categories are P1 to P4. P1 being urgent and emergency. That has happened throughout COVID, and so anybody requiring emergency surgery had emergency surgery, and we cohorted within the screening regimes you get. Our P2 patients, working our way to the P4 that are the more routine expected to wait. Our P2s have been identified as require surgery in the next 4 weeks. We had 174 of those when we started 3 weeks ago. I'm pleased to share that that number is now less than 70, and we plan to have no patients within a P2 category by the end of July. Of course, the titration is that every week a patient might tip into the P2, but our plan is to have nobody that's within that criteria that surgeons want to see within 4 weeks is cleared by the end of July. We are in a good position with that, and there are always patients whose condition, as once again outlined by my colleague, medical director at BHRUT, we are very concerned about access and equity and those patients that are able to isolate. And there are patients within our P2s that we are having to work very hard with to get them to come and have their surgery. Our medics are frontline with this and are working with them, and we will just handhold people as far as we can. So the elective programme is possibly one of the most challenging parts. They're all challenging, but this finding an area that's technically green, cutting it off from the rest of the hospital, swabbing people in and out, you can only imagine what it's like to try and keep that area green, has been, touch wood at my desk, been successful thus far. And I think as we get more proficient at working with these new ways of working and with new surgical techniques, our surgeons are being confronted with all sorts of isolation pieces of kit so that it's not aerosol generating, and we will no doubt learn all sorts as a result of this period, which will longer term hopefully support better outcomes for patients, because it's not just COVID, as we know, there are many other infections and challenges within a hospital environment. So whilst it's difficult and intense, we hope that we will have better services as a result. Probably I'm working around my building, please excuse my brain. We then move into outpatients, and these are weights that your colleagues were highlighting. Outpatients has seen the same evolution as primary care has, with the use of telephone consultations, the potential for video conference calls, and our challenge is to get some 40 to 50% of all of our outpatient activity using alternative first contact models. We will work hard. Any service that says that this is an approach that will serve them well, we will do everything we can to equip our teams to be able to do that and start working away at our waiting lists. And I'm sure my colleagues will share the emergency care in many ways, whilst arriving every day and causing us flux every day, that where our greatest concerns are these unknowns and how patients are managing, and we want to get to our patients as soon as we can. I can't give you definitive timelines by specialty, but we will aim to so to do over time. Okay, well, that's fine. That's a very full account. I could see Dr. Smith nodding as you were talking about green areas and so on. Oh, it's a shared problem. And just to say, I mean, perhaps I should have said it earlier, I mean, we do appreciate
just how difficult all of this is. So we're trying to walk a bit of a tightrope, I suppose, on the one hand, making sure the scrutiny function continues, but on the other, trying to give you as much latitude as we reasonably can do, because we just recognise this is unprecedented. And also, I think that people have personal challenges as well as professional ones as well. So I do have Councillor Mrs. Nolan with her hand up. So if you'd like to go first, Councillor Mrs. Nolan.
Thank you very much, Councillor Zammit. And I think you've actually taken the words right out of my mouth. We are living in unprecedented times. Sorry. Okay, sorry, apologies. Unprecedented times, and I think that, you know, this is a learning curve for all of us. We've never had to experience anything like this before, and I think our clinicians and staff are doing the best they can in what is a really, really difficult situation, whilst we at the same time are trying to obviously challenge them to make sure that we're hopefully we're getting the right service. I mean, I think for me, from a personal aspect as well, concerns about the pausing of cancer treatment and the effect it would have on patients. And that's really what worries me, because this is, I'm speaking from personal experience now, as having had lost a daughter to cancer, that I know that I can't imagine how patients would be feeling now, not being able to access treatment during the crisis. And I think one of the comments that he made about the thrombectomy services as well, and how that's been progressing. I think you know, there has been a lot of concern with people about not being informed about the changes and losing rights and so on, and engagement and consultation and so on. And you know, we've got to recognise that communities are very different across the boroughs, as has been said. And those who are digitally excluded, for example, and that probably brings into the older generation, which Councillor Islam identified right at the very beginning about our care, about patients being discharged and going back into care homes. And we know the difficulties there, and there's been lots of criticisms about should they have been tested, should they have not been tested, and so on. This is something really difficult for our older community. And I mean, a lot of them are not online. How on earth are they going to get online? Who is going to pay for that? You know, so there's lots of questions we do need to answer. And I think the other question as well was surrounding blood tests at KGH and Queen's. They were suspended, although I do understand today patients have been attending Queen's to have blood tests. But why is so many services being transferred to Queen's when you do have KGH there? And that's another thing that concerns me, that you're marginalising so many of the services and sending them to Queen's when KGH should be doing some of the work as well. So I know there's lots of questions there, and I'm just throwing a lot of questions into the mix. But main concerns are, can we get our patients back to having treatment, coming up to surgery and so on? What's the kind of waiting list, and when do you think maybe that we should start getting back to some sort of normality? I know Claire mentioned about whips. It's really trying to get hold of those untouchables, the people that haven't been going to the doctors and so on. And they really do need to be seen. And what really, really worries me, another huge big issue, is surrounding mental health as well, because throughout all this situation, this is something that I think is going to be a real challenge for us going forward, people with severe mental health issues. And thank you, Chair.
Okay, so let's try and untangle that.
Lots of questions.
I know lots of questions. Well, that's no problem. That's why we're here. So I just think that probably I think we ought to give Dr. Smith and Claire Burden first go at this, and Kerry, if you want to come in later on, that's fine. But let's start with Dr. Smith around some of these really difficult issues. I think blood tests is a very interesting one, because I keep on mentioning Hackney. I don't know why I keep on mentioning Hackney. Sort of like the promised land, really, isn't it? Actually, that's Tower Hamlets, not Hackney. They've got to everything in Tower Hamlets. You know, it's in Tower Hamlets, sorry, in Hackney, that they have phlebotomy services in every surgery. Yeah. But here we don't. So why, again, is this huge disparity between inner London and outer London? That's perhaps a slightly separate issue, but Dr. Smith, can you make sense of Councillor Nolan's questions and give us a start of a 10 on this?
I will try, absolutely. I think, first of all, picking up on the issue about cancer treatments. So the cancer treatments have been carrying on as usual. It's the issue of the diagnosis of cancers. And this is a London-wide and a national concern, that because the diagnostics that enabled you to make the diagnosis in the first place were suspended for a period of time, this is a significant concern. So one major area of focus in North East London is the approach to cancer diagnostics and the access to cancer diagnosis. And a big area of concern is about bowel cancer. So there's a significant piece of work that's been going on across NHS London around improving the access to bowel cancer diagnosis. So some of that has been about looking at, actually, with the infection control safety guidance, can we get more patients into the available cancer diagnosis services? How do we stratify the risk for patients? So is there a better way of doing this? And there is a sort of a new system in place that says you have about a poo test first. And if your poo test is negative, actually your bowel cancer risk is low. If it's positive, we need to get you into the service. And all those services are opening up. And then there's a big piece of work that's going on across London that says we need to actually open up more diagnosis centres. And I'm really pleased to say that we are making a very strong bid for those services to be increased in Redbridge in particular. The second thing was about the digitally excluded. I have to say, my parents have passed on, but I have a more digitally engaged and enabled 90-year-old godmother than I am. So, but absolutely, it is a concern that if we're moving everything to digital, how do we make sure there's no health inequality there? And I think that's about a collaborative approach, both, from the acute sector, primary care, but actually with local councils about how we improve access to digital access for populations. The third thing was about phlebotomy. Absolutely, we have opened some additional capacity at Queen's this week for the population, but actually we've been opening it up at King George's. It may have not hit the headlines as much, but King George's has been providing critical phlebotomy now for several weeks. Actually, it's the new bits that are coming online around Queen's. And then the last issue about normality, 18 months to 2 years. I cannot see it. I mean, we're already seeing across the nation where we think things are calming down. Leicester suddenly put back into lockdown. Outbreak at Hillingdon because a member of staff was infected. I think we're going to see things popping up constantly, actually, that will slow us all down in terms of recovery. Kerry will probably, GP phlebotomy, Kerry can probably answer. Absolutely, it's an area of conversation.
Okay, well, sorry, just let me interject for a minute. I'll come back to you, Kerry, don't worry. I just say I think that's a really good response, and thank you very much for that. Just additionally, if I could, Dr. Smith, ask you whether the sort of chemotherapy services which are currently being provided out in Brentwood, whether the pharmacy has moved out to Brentwood as well, or whether the pharmacy at Queen's is still making up the treatments for patients and shipping them out.
So the pharmacy at Queen's is still making the treatments, but actually we've had no issues that I'm aware of, certainly. So there's some chemotherapy that happens in Brentwood. For the blood cancer patients, it's still happening in a protected area at Queen's.
Okay, I just mentioned that because, of course, we were told that unit at King George was closed because it was so difficult for the pharmacy to make up the solutions and get them over to King George. But obviously, it's not a problem to take them even further up to Brentwood. You don't have to answer this. It's something we'll return to in due course.
So but I'll make a note. Thank you.
Okay. So I'd now just like to go back to Claire Burden from WIPS, because I think it's important. If you could answer Councillor Mrs. Nolan's questions as well, that would be really helpful. You don't have to spend long on it, but just give us a brief view. Thank you.
Yes, of course. As explained by Dr. Smith, we are current treatments within cancer have been maintained within St Bart's, and patients were cohorted in order to keep them as safe as humanly possible. And of all our hospitals, I have 23 entrances on site to try and manage. The St Bart's have 3. And so there are sites that you can make safe at a slightly different pace when you're dealing with those sort of occurrences. And it's not until you're staring down the lens of trying to manage patients and flow that that local nuance about how difficult it is in different places does make comparing one site with another a really complex, difficult task. Not least anybody who knows Whipps Cross, I don't think I have a single ward that mirrors itself anywhere in the building. It's unique from the front door to the back door, which is lovely, but not ideal in terms of trying to get single flow traffic. The digital era and our elderly population, I completely agree with my BHRT colleagues. What's interesting in our early investigations is that they were some of the most tech savvy. And it was actually our more deprived populations who didn't have access to digital mediums that proved some of the most challenging, and they were younger people. So I think, and this perhaps picks up on one of the Chancellor's earlier earlier comment with regards to BAME and our whole approach to inequalities and how are we going to tackle access with multimedia. We have our work cut out, but through this COVID exercise, the way we partner voluntary organisations, how we think differently about the provision of support, the cross working with our council colleagues. It was a very difficult period to work through, and the legislation came through, the transition from the CARE Act into the COVID-19 discharge criteria. We were given 3 days notice to do that. And so it's, once again, there's a real credit to the system that we did things in 72 hours. But the learning and what we put back in the system just has to be on that holistic foundation, in that we want equity through our system, and that's really easy to say and very complex to unbundle. But all we can do is keep chipping away at it by working through our patient lists and asking. And you mentioned Healthwatch at the very beginning of this. We are going to need our Healthwatch partners and Scrutiny and so forth to help keep nudging boundaries about how we equip communities, health, social care, that whole infrastructure to be able to provide access in a different way. And that quickly becomes utopic, so I will stop there. Back to the questions. We've lost 3 months worth of productivity in an era before I was only allowed to have one person within 2 meters of anybody. So not only have we got the 3 months to catch up on, our, excuse the manufacturing terms, but our whole efficiency and productivity about getting people effectively in the building and out, we're working on baselines that don't exist yet. So we have a real challenge on our hands with regards to forecasting, and all of us as providers will be doing the same thing. There will be a lower limit and an upper limit, and on a daily basis, I might ping pong between this upper and lower limit for a long time, whilst we're able to identify patients that work through a particular pathway efficiently, and or determine that a pathway that we've designed just no longer is effective in the way that it was. So I can only offer the same commitments as BHRUT, in that without doubt our medical and teams and those supporting waiting lists and getting information to patients have been outsourcing and outreaching to patients as much as possible to keep them informed, not least those who have had appointments rebooked, and that whole traumatic affair of having finally getting to the top of the waiting list, getting an appointment, and then it being knocked back. So our telephone lines and our appointment lines, very similar to our activity. The patient lines dropped off to 1/3 of their activity. I'm pleased to say that patients are calling, which means that, you know, the more people are getting in touch with us, the more information we can give out. So whilst we might not necessarily be giving people the answers they want, when am I going to be seen, we can at least make sure that people are kept in the loop about where they are, and most importantly, with a good range of questions. If we need to get them to a medic and or they require any advice, we can pick them up at the earliest point.
Okay, so I think I'm going to bring in Kerry in a minute, but I just wanted to say that I think both those answers show just how much there is in all of this. We could spend a week really discussing these issues, and obviously we don't have that sort of time. But it's a real headache for me, the vice chair and spokesperson, to try and work out a work program that addresses some of these issues in some sort of order of priority. So, I mean, I'm really grateful for the sort of level and depth of response we've had from both yourself and Dr. Smith. I think it's really helpful. And now we're going to have to put our thinking caps on about how we're trying to integrate that into our scrutiny process. But Kerry, was there anything you wanted to add to that?
No, I was actually just to pick up the phlebotomy availability in primary and community care. So that was the work that we started pre-COVID, and then obviously it halted through there. So we are seeking to bring phlebotomy out, if you like, much more of it. It's part of our North East London primary care recovery plan. It won't necessarily be in every practice, because some of our practices will be too small with social distancing to run that and other services. So we're looking at each PCN that they will provide it. So some of this will be provided by NELP in community hubs right across BHR, and we are in the process of restarting those. And one of them is actually provided by Berks Health anyway in Wanstead, and we're working on a restart date for that. But the primary care local incentive scheme, which is what will fund the primary care element, is being actively worked on at the moment. So we would hope to get that going live very, very soon. So you should start to see, if not in every practice, certainly in every PCN, and hopefully in more than one practice per PCN as well.
Okay, that's really great, because I'll be able to get my blood test done as well, won't I? Now I have Councillor Noor. Are you online for us?
Yes.
So do you have a question for us?
Yes, I do have.
Carry on, sir.
Okay, thank you, thank you, Chair, for allowing me. I'm sorry for because of technical reason I couldn't join straight away because there's some problem there, but finally I'm with you. And thank you for wonderful questions and answers. I have two questions specifically. One question already asked by the Councillor Chaudhry, but I have one leg as well for this question to answer. And I will ask the question first on this regard about the BME, communities, COVID, and the trust issue. And I think so the one part answer already given, but my question to this specific question, and I'll expect this specific answer as well. I read this similar question, but I'm not satisfied, but I think this is the right forum for me to ask the question. In terms of the BME death rate, and we see the different kinds of report come off from Public Health England about the identified Bangladeshi community, some of the report about Pakistani community. Well, the question about how this specific data come from, because we know that from our experience and the law as well saying that in the death certificate there is no ethnicity is mentioned specifically. So how accurate these reports are and data are, and how reliable this information and the report is in conclusion. And whether we heading towards some sort of a misleading finding, this can be also dangerous for our credibility as well for the long run. And if these findings are not credible, the information data are not accurate, then obviously it will help our resolve as well to solve this problem as well in the long run. So my question to you, because I see this similar question in the last health scrutiny meeting about Red finding as well. Where this data come from? What is the lead of this data and conclusion? Second question to you, in terms of the testing. From my own experience, I went through these procedures, and unfortunately, alhamdulillah, and thanks, I'm fine at the moment. But there was no compulsory testing facilities. I understand there is now. But when it was a voluntary testing facility was there in Red scheme, But my understanding was the participation was not really very good. In terms of the track and testing or tracing, how confident we are that we have a mechanism and system in place that we are accurately tracking, and if this something pandemic is not going away, unfortunately it will remain with us for a long time. How confident we are that we can address this issue that is not going to out of control. Thank you.
Just bear with me. I just want to say that on your first question in relation to the data reliability, sorting it out, and so on, I think you're absolutely spot on. And I think when we take some of these issues to do with Black and minority ethnic communities, we want to do it at a time when we have sufficient data available to be able to come up with some clear answers. At the moment, I think it's still a little unclear, comorbidities, factors such as obesity and so on. So we're not absolutely clear, but obviously it's a hugely worrying area. And before I turn to...
Chair, before you move on, please excuse me, before you move on. Yes, I appreciate your interjection in this regard that we need to wait for until further data. But my specific question to you is in here. Unless we have reliable data, how can we come up with the conclusion and publish a report and present in health scrutiny as well? And the last health scrutiny meeting, this issue came. And also I raised this question to other meetings as well with the executives and councillors as well. And if this you are right, and I think so you are right, that we don't have accurate data yet. So why are we trying to make an assumption or conclusion without a basic foundation of statistics or data that is reliable? Well, because this is giving the wrong impression to the community, because my community is suffering. There is a mistrust about this report, and this is also letting down the community as well. We know there is because of this issue, there is underlying health inequality established, but doesn't mean that we need to find out something on the basis of assumption.
I think you're absolutely right. I was just simply seeking to reinforce what I think are absolutely correct views you're expressing. But I want to bring in the expert now. So Gladys Zapier, our Director of Public Health, wants to respond to this. And before I turn to our invited guests, I'd just like Gladys to make a comment.
Thank you, Councillor Noah. Just to reassure, this is a national report published by Public Health England. You're quite right, in the death certificates, it doesn't have ethnicity. This report concentrated looking at hospital data across the country. And we were there was a big engagement, and we were part of the borough as well. I was there with Professor Kevin Fenton, who's actually leading on that work. So there were two reports. One was the data, and then there was another one, what does that mean? So there's another session in London tomorrow, really to look at all the issues you have raised. It's not ethnicity that is the risk, it's about all the other, there are a lot of other things that contribute to it. But we need to really look at it. And also locally, you're absolutely right that we need to manage it well, because we don't want people to be frightened. So I think someone previously also talked about, so when we are looking about inequalities, there's some immediate actions for us. So we are talking about a second wave. It is not if, when. So we need to be prepared. So our communities, they know they're not frightened if they're to go to hospital, when to get help, when to get tested, all those issues. And then we also need to be looking at the long-term impact. So we need to support, we talked about mental health, obesity, all of those things. So from a data perspective, it has been done through that. And across Northeast London, I know Barts have already done it, because as an internal, they looked at data across Barts as well, because they looked at hospital data, because they've got the data there. And similarly, we are looking at, so I think Kerry and across Northeast London, we're going to invest in some extra public health resource to look at the similar issues in BHR as well. So you're right, there's a national data, but we really need to look at what is happening locally. So we equally share with you your concern. So we will be looking at that. And then on the issue of test and trace, if I may, Chair, as well, there's what you call Pillar 1 testing, which is done in hospitals for patients, for healthcare staff, then Pillar 2 testing, which is done wider in the community. So nationally, we're increasing capacity for test and trace. So if anyone, so there's loads, there's regional units, there's a home testing that people can test for. But in Redbridge, we have got the military, they provide a testing. But I can tell you from today, we are also going to be increasing testing facilities for Redbridge residents. So that will become available from next week as well.
Okay, well, I want to move us on. I dare say that others might wish to contribute. I would just make the point, Councillor Noor, and also to Councillor Chowdhury as well, that I think this is a very hot issue, and I think you're both absolutely right to be raising this. And what I'd like to do is to make sure that we can, as a committee, address this properly as we go forward. So I think what we might do is try and put this as an information item at the next meeting, so that we're constantly tracking progress and what's going on. But I think everyone shares your concerns, and I think Councillor Noor absolutely spot on in terms of saying, well, you know, where did they come from? How reliable are they? And obviously, the Director of Public Health mentioned comorbidities and other factors which we need to tease out before we can take a final view. So would it be okay for us to return to this at the next meeting, perhaps just for a brief update from Gladys Xavier? Would that be okay with me? I see people nodding.
I think Councillor Santos wants to come in.
Okay, so Councillor Santos, the floor is yours, sir.
I think the comments I've just heard make me feel quite anxious, and the reality is we do have enough evidence to suggest that some people from Black and South Asian communities are disproportionate risk of serious illness and death. And if we don't, and I'm quite anxious that we're doubting the PHE report, one. And actually, I've seen the report that was done by Chloe Orkin et al. In Barts, which was looking at 1,700 patients there, which did also echo some of the findings there. There is some work that we're bringing to People's Scrutiny Committee next time to start to engage with and connect with communities about raising awareness of some of the issues and mitigations that people can take, because we need to be able to equip people, we need to be able to equip communities in relation to a second wave and to be addressing some of the inequalities. In a rare moment of disagreement with Councillor Zamet, I am beyond data. We need action now, and actually, and that's where I'm focused. And I just wanted to share that with the committee. And what I'm really pleased about is that Gladys and her team, and you heard the work from Kerry and her team, and in the different parts of the health system, are also working on this. And certainly within Redbridge, we have a COVID-19 and BAME steering group. We have a and a COVID board, which will feed into the Health and Wellbeing Board too, so that we're wanting to start to take some action to, as Gladys said, not to frighten people, but actually to equip people, to inform people, to enable people, and enable communities.
Okay, well, I'm going to take that on board. I think that's a really useful contribution. What we need to do, I think, taking your sort of theme of action, not words, is to make sure that that COVID working group, that the minutes and any reports they produce are circulated to Health Scrutiny members, and indeed, I think perhaps the wider council, so people are reassured about the action that's being taken. But okay, so that's really helpful. We're doing more around COVID-19 and BAME communities, and that's really good. But obviously, we can always do more. Now, I'm conscious of time, and I'm conscious of the fact that Bob has been sitting here very patiently for a long time. So I'd like to bring you in now, Bob, to just say a bit about what's happening on the mental health front. And we've also got the 117 step-down beds that NELFT have provided on the Goodmayes site. So just bring us up to date with what you've been doing.
Thank you, Chair. So I'll break it down really into a more sort of global sort of NELFT response, and then perhaps a little bit of a Redbridge sort of centric response. So on a whole basis, NELFT has been obviously supporting the sort of drive to combat COVID on a community basis. You're quite correct. We were asked to stand up 117 beds on the Goodmayes site, which were step-down beds of sort of intermediate care type. which were to support the acute hospitals to move people through. They were developed and delivered in short order over about a 4-week period, including sort of refurbishing wards from scratch, which was quite an amazing thing. We, as a whole, as a trust, we deployed 500 staff from their usual places to support those sort of critical services, and this was done quickly and efficiently. A lot of the staff from our 0 to 19 health visiting services, particularly in Redbridge, have gone off to actually support those sort of efforts, because they often are at their core qualified nurses, so they had skills that we could redeploy and retrain people to use, which is really, really helpful. We've continued to sort of maintain 24-hour mental health support via a support line, and that's been well used throughout the sort of crisis, and people have been contacted out, not just people who are known to our mental health services, but people who are just generally distressed and concerned, and we've been able to guide those people to some assistance. In terms of the more localised sort of Redbridge response to things, now as members will appreciate, we are an integrated health and social care service on the community between health and adult social care in Redbridge. And we did an awful lot of reorganisation, as the rest of the health service did. We've heard from partners in Barts and BHRUT in very, very short order. So as part of our response to sort of COVID, we were needing to manage the out of hospital care pathways, and there are 2 elements to that. One is the social care response, and one is the health response by NELFT. So we obviously oversee both things. So in terms of social care, we deployed staff into the discharge hubs that were developed for both BHRUT and Barts, based at Whips Cross and at King, actually based at the edge of King George service for Queens and KGH. And those services were operating 7 days a week, 8 to 8, to facilitate hospital discharge. In terms of our community nursing services, we reorganised those so they were operating 7 days a week from 8 AM till 10 PM on a shift basis, so they could pick up people who were coming out of hospital who had high levels of need. And we were seeing people with higher level of need in the community who were more unwell than perhaps we would routinely see in some particular cases. The first contact team, which is a single point of access for social care and community health services, we also moved to operate 7 days a week, 8 AM to 8 PM. And that was very well used at weekends by people. Interestingly, a lot of people who were just making general inquiries about things COVID related, and actually in terms of seeking some assistance or some support. We also supported the wellbeing service, which was set up by the Borough under Adult Social Care. This was the service that actually was managing people who were shielded, for want of a better phrase. So people on the shielded list, we contacted, there were about 8,000 of those people, and then there were a further 27,000 people who were identified as having some form of vulnerability, who would need checking or some sort of support. From that group of people, there were 1,800 people who required food deliveries from the DEFRA scheme, and again the wellbeing service actually coordinated that. And we have done outgoing calls to those people to check on their wellbeing, see if they've got any particular needs, and we have networked in services or to the appropriate agencies where people have identified needs. So that could have come through to an health service, it could have been primary care, but fundamentally we worked in partnership to make sure that was well delivered. Our nurses in the community health services were supported care homes with visits, undertaking care and treatment for people in their care homes. When they identified issues in the homes, it could have been in terms of support for infection prevention control, or where it could be maybe issues around PPE. We liaised with colleagues in London Borough of Redbridge Commissioning Unit and Public Health to ensure that support was actually offered to care homes. And we've actually had staff go out to care homes at the request of our colleagues in commissioning to make sure that they've got the support to actually be able to deliver the care to people who need that help. Members may not be aware, but the Holiday Inn on the A12 at Newbury Park, which I'm sure we're all familiar with, we actually took over this completely in about May time, and that was 130 beds, and this was again additional capacity was put into the system to support the hospital discharge process, and as part of that, adult social care recruited from our extra care services and agency a whole staff team to actually be able to support people going into that, some of whom would have been COVID positive, some of whom would have been non-COVID, and we had the actual place divided into hot COVID floors and cold COVID floors to actually support the additional capacity. NELF identified staff to go in and support that particular service from both a nursing and therapy point of view. And fortunately, from that point of view, although there was 130 beds commissioned, we didn't use many of them, I have to say, in the grand scheme of things, which I guess is a success story, because it maybe suggests that you know, things didn't quite overwhelm the system as we might have worried they were going to at the beginning, which is good. We also have an end of life service that actually works within the community. They have been out working both across care homes, but also with people in their own homes to provide additional levels of support. Sadly, we've found that during the COVID period, people have been discharged home in end of life, and the period they've been with our services routinely been shorter, I guess, than maybe we would normally be working with people, which says something about the crisis I guess we're in at the moment. And finally, I guess that the thing to talk about is our IAPT and mental health services. So from a mental health services point of view, we managed to reduce down the number of people who were admitted to hospital during the COVID period. So we managed to manage the bed base fairly comfortably, I think, during the peak of the outbreak. Our CAMS, learning disability and mental health service, moved to an online model where possible to actually work with people to avoid face-to-face, so that we weren't potentiating the possibility for infection spread. I have to say that some of that's been really successful. Members won't be surprised to hear that young people actually really rather liked an online offer, and they were quite keen to engage with us via video link and various other ways. Interestingly, it worked really well for our psychological services, and we actually have found that doing groups online, we've actually increased the interaction, number of people attending for groups, rather than a routine face-to-face model, which is something we need to look at to understand a bit more, but it's certainly something that's gone up. Our mental health services were deployed, overall secondary mental health services, to make sure they could support people who had the highest level of need. So when people were going into crisis, we were picking it up quickly and actually supporting those people and hoping that the crisis didn't get worse. And in the majority of cases, I think we managed to pick them up early enough. I think there will be an issue coming out of COVID into recovery. We're seeing an increase in referrals to mental health services now, and I guess that's to be expected, because there were people who are known to us, of course, who were perhaps a little bit anxious, who didn't want to engage with services during the COVID period for fear of infection, which I guess has gone off a little bit more. But we've also got a new cohort of people coming forward who are, as we all know, I think, finding that the stress of sort of lockdown and the difficulties and pressures around employment and not employment difficult to cope with. And we are supporting that via our IAP teams, who are upping their offer, I think, in terms of those sort of people. And our IAP team have also been really good in terms of working with borough services. So where we've made an offer sort of from IAP to general London Borough of Redbridge services to actually support staff teams across the council. And this is an offer that's been well taken up, and we've been receiving a lot of calls, particularly through weekends, from Redbridge employed staff, but also from the Redbridge population. We've seen an increase in the calls for people who are looking for support from IAPs, and I suspect that as we continue into the recovery period, that we will continue to see an increase in those particular calls and requests for assistance. We now have a recovery and restoration group set up, supporting bringing our clinical and non-clinical services back online where appropriate in community. Our estates team are working to look at premises, and of course in Redbridge a number of our estates are actually London Borough of Redbridge owned, so we're working with the borough to make sure that we don't bring people back into the workplace who don't need to be there, because it's still the mantra, obviously, but where we do need to bring people back, that we can bring them back safely, and we can apply social distancing and appropriate guidelines to make sure that people are safe in doing it. And a number of our services are now going to an online sort of type booking. So, for example, the Barking Centre, the Barking Community Hospital Walk-in Centre now has an online booking system for people going in there to manage the COVID sort of aspects of thing, and also the flows, which is working really quite well. And has already been mentioned, I think, by various colleagues, and Kerry, NELF is implementing the community phlebotomy services across BHR services. We're standing up some services that we previously provided, but we're also implementing some new sites. So we picked up, for example, Loxford Polyclinic from BHR UT, and we began operating that on Monday of this week with 5 chairs. which will give you capacity hopefully going forward with people. And we've also moved that service to an online booking system, which seems to have gone quite well. So people can now log onto a system and book their slot and come for a phlebotomy bleed, which allows us to manage obviously the dangers around COVID, but also is a more efficient and effective way for people to access phlebotomy. And I think that's all I would have to say at this point, Chair.
Okay, well, that's another really impressive tale, isn't it? And I mean, I suppose if I say well done, it sounds so trite, doesn't it? But I think it is hugely impressive, isn't it? I just want to pause for a minute and go back to Councillor Santos, if he's still with us, and to say, just thinking about what you said about the COVID working group and the concerns which colleagues have, I wonder whether it's possible for either Councillor Chowdhury or Councillor Noor, or both, possibly, to be included in the COVID-19 working group, which would give us a very direct link between health scrutiny and the work you're doing. Just a suggestion, and you don't have to answer now, perhaps we can follow that up after the meeting. Having said that, I'd now like to throw things open to members as a whole. So does anyone have a question, a comment to make, perhaps?
Yes, certainly I would, Neil.
Yeah, okay, carry on, Mr. Cole.
Thank you. I don't think when I've been raising my hand, I'm not totally sure it's being seen. I have a few questions and comments from the various presentations and from the report. One, you've mentioned that quite a lot of it is moving towards online, and I think it applies to all of our guests. I'm very concerned that if you're getting away from face-to-face, that when there are issues, whether it be mental health or physical health, sometimes patients will have difficulty articulating their problems and would need that face-to-face which to be drawn out, and for the practitioners to actually make better use of body language. That's one of the things we lack on Zoom meetings. You don't see body language, and there are issues, those particular issues. The other one is testing. I mean, Councillor Mrs. Nolan raised about the blood testing, but it is about testing generally as to how well that is coming on, because I met one of my elderly neighbours this morning who's got to go and have a blood test and x-ray and doesn't know where she's going to go or how she's going to do it. Those and any other diagnostic tests, I mean, they're the two most common, and whether there is a case for NELF to expand its offer of actually doing home visiting. I know when I was recovering from treatment from cancer, and NELF came around and took blood from me in my home, and whether there should be an expansion of that, certainly for those that are on fasting blood tests, on those. And with the mental health, will you be, I think it's more to Bob, will you be actually employing more staff? Because you say there's going to be a growing demand. Sometimes there can be a waiting list for it, certainly for one-to-one consultations. I know you do your group ones from that area. And then the other area is for, the BHRUT going forward. I am very concerned that it seems to be a one-way street going from King George's to Queen's with services and nothing much coming back, on whether Queen's has the physical capacity. I can understand you don't maybe want to split services over two sites, but I think maybe the services should be split more equally between the two. And certainly bearing in mind the expansion of the population in Redbridge and the expansion of population in Barking and Dagenham, which certainly down at is it Barking Reach or Creek, all the homes going there. And I would have thought for many people, it's certainly in the Barking half of Barking and Dagenham, would want to come to King George's will be easier than trying to get to Queen's, and how much that is being borne in mind when you come up with your future planning. I think they are my main ones, but I am concerned about us getting forward with as near to normality as possible and improving testing of all the various sorts, because there aren't necessarily going to be so much in hospital. And I think Whips Cross were very quiet, didn't answer Mrs. Nolan, Councillor Mrs. Nolan on that part earlier. So those are my points. I've got loads of others, but I think I'll keep that for another night.
Okay, well done. Well, I think body language is definitely yours, Bob.
Yeah, body language I can talk about. I can pick up on a few points there actually that have been raised. Absolutely, quite right. We're not suggesting for 1 minute that our offer for mental health services remains completely online. It's something we've done during the COVID period. I personally don't think that's the right way to go. Ultimately, I think there's some learning. I think there are some things we can do different digitally, more effectively, and we'll learn from that and do those things. But actually, it's quite right what's being said. If you're trying to assess someone's health and well-being, there's excuse me, a lot of other factors other than what people are saying. So that would be the first thing. Second thing I would say, in terms of phlebotomy, we've got a community phlebotomy service in Redbridge. It's actually not that time efficient to do many visits in that particular way, but it's a service which remains, and we can look to keep it under review as to what the flows of people would be to community phlebotomy in their home residential, or whether it's going to be in actual bases. There was a third one which I've forgotten, but it was two. There was mental health phlebotomy. I'll come back. Councillor, could you remind me the other point you made was for me?
I'm not a councillor, but it was testing generally, not only, but other testing, which I think it applies to all areas.
Yeah.
And also whether you will be being able to expand your staffing in order to do a better response, because I think the demand outstrips supply.
The demand is certainly very high. You're absolutely correct. That will be something that we would keep under review with commissioning colleagues, and to look at what resource we would need to bring in and make those sort of requests to commissioners with evidence business cases. So it's certainly something we would keep under review. And you're absolutely right. I think we may well see an increase in demand over the coming months as we go into recovery for mental health services.
Okay, I just want to bring in Kerry, if you're still with us, Kerry, on Mr. Cole's final point on it's one-way traffic. Things get closed at King George, and it all goes down to Queen's. So that's a very honest statement, I think, by Mr. Cole. So what would your comment on that be?
I'm not sure that is entirely accurate. So my understanding of the changes in BHRUT is that an awful lot of the planned care of the green site activity, if you like, is actually going to take place at King George Hospital. So it's not, I think, about one-way traffic. It is about moving things around to accommodate the infection control requirements that we have in place. Magda will probably want to add to that from the clinical or medical perspective. But I don't think that that's necessarily quite accurate, and certainly last time we did spend some time in this committee talking about some of the activity that was actually moving over to King George as part of establishing that green capacity. I don't know, Magda, is there anything you want to add to that, or not really?
So absolutely, Councillor Zammit. I think just to comment on the online rather than face-to-face appointments, the point is very well made, and I think there is going to be a huge piece of evaluation about the benefit to patients of online, and it will be beneficial to some people and not to others. And there will be circumstances where it's not going to be beneficial. So right early on in the process, for example, our cancer doctors said that for a first cancer consultation, we will not do online, but for the follow-up, when we have the relationship with the patient, we will. So that's the first thing. So that needs evaluating. In terms of the one-way street, actually, our focus has been on opening up services at King George's, particularly related to the planned care services, creating the green capacity. That's the majority of the focus of our green pathways. So in terms of planned orthopedics, many services, planned elective surgery, that's the area where we focus the opening up of the pathways, as is outpatients in that plan. We've identified a what we call a green or a COVID protected critical care unit at King George's. Historically, we would be cancelling patients at King George's for orthopaedic surgery because we didn't have the ITU capacity. That's now been removed. So it's not a one-way street. It's about presenting the balance. And I think possibly on reflection, it's about our presentation of the balance that needs to be better. going forwards, rather than this sort of feeling that everything's moving towards Queen's, because it absolutely isn't. So I think we can bring back that balanced presentation.
Could I just add one thing to that? I think maybe it is right. It is the perception in the report, and may it be helpful to this committee if you actually listed what services you're providing at Queen's, what you're providing at King George's, what you are proposing to do in the future, because that's partly what I was looking at. It was that, and how those services are going to be managed in future, and have it listed out. And are you looking at it that you're looking at King George's to be more like Bart's Hospital is, and Queen's as the London type hospital, in the way that the services are provided? Because Bart seemed to do elective surgery while London does the A&E and the emergency.
I think that touches on a really very important point, which I think we need to really flag up, which is that whatever happens in the short term, there does need to be a sort of long-term strategic plan, which sort of shoehorns this all into the partnership's response to the NHS long-term plan. Obviously, the initial response was done pre-COVID, but what really needs to happen here is to look at where we're going to be in 10 years' time, rather than making short-term changes, which might be expedient. We really need to see where we're going in the longer term, and that's really a major job for the partnership, I think.
Yeah, that was the point I was trying to make. Okay,
so we're clear on that, and we'll park that with you, shall we, Kerry?
Yes, this links into the clinical strategy and other stuff. So certainly we can. I'll talk to Magda and we'll think about how we bring that back.
Okay, so I have Councillor Mrs. Islam now.
Sorry, my questions have already been answered. Thank you.
Okay, so I have Councillor Noor.
Just to thank you both, Edward Bobs, for his presentation. And I don't have no question on this regard, but just one comment about, in terms of your observation about the presentation of Councillor Shantus about the COVID-19 work group. I think, sir, you are absolutely right in here that we are in this situation. We want this get right, and we want to see as well that working group is widen its horizon. And obviously, certainly, and I will be delighted if the opportunity is given. And I think that this is necessary for us to do so, because we want to get this right and right for the future as well. Thank you.
Okay, well, that's absolutely spot on. Councillor Morgan Thomas, I have your hand up, sir.
Thank you, Chair. I did have a couple of questions on a few points of interest, actually all coming around from what Bob's mentioned in his report, and something I mentioned briefly at the end of our last meeting around the sort of the safety of online access, the actual safety of the appointments, which is one thing, but also the perceived and potential dangers of fraud and things around, people posing. And actually, since I mentioned that at the last meeting, I've had a couple of reports from constituents of people having, what are obviously bogus phone calls, saying, oh, this is, I think in one case it was someone claiming to be the council, in another case it was someone claiming to be very spuriously just the NHS. I mean, these are quite, spam red flags if you know what you're looking for, but actually if you're an anxious person, and particularly a person who hasn't had much contact, who's now connecting with something online or over the phone, then it's a real area of concern. I'd be grateful if any of the services talk about maybe a little around how patients are being interacted with, things to look out for, ways they're reassuring people. And there are a couple of things around mental health provision. I'm conscious we don't talk very much, particularly about children and young people's mental health provision in the borough, but and there was some mention of, currently children and young people accessing service. But I wonder, particularly with the recent news about the likelihood of schools going back in September. I realise being in this meeting tonight, unfortunately, we've clashed with another meeting with the Director of Education to help reassure parents and children this evening. But, in terms of whether, say, this summer holiday, I say in inverted commas, what sort of support we're likely to be providing for children and young people looking to possibly go back to a very, very different start of term in September. And finally, just as I have a NELF hub, I don't know if that's quite the right word, in my constituency of Melmead, thinking particularly about very acute mental health conditions and the prospect of, excuse me, people who've been brought in as part of the reach out to the homeless in particular during the pandemic, that the prospect of people, you know, having been in housing, potentially not staying in it again, and the prospect of, you know, also people who were sectioned, again, coming out into a post-pandemic world afterwards, and what that looks like for the really acute level going forward. Thanks, Chair.
Okay, well, I think Bob, you could probably handle all those, couldn't you?
Yeah, I can. So in terms of the cold calling of people, I mean, that's clearly an issue which is potentially fraudulent, I guess, probably in nature and concerning for people's well-being. These things are monitored via the sort of community safety sort of services within the borough. And if there's any sort of particular concerns picked up or people report things, they will check to see whether the validity of those particular calls is with our good selves. What I would say is we don't tend to cold call people, as you'll understand, from an NHS perspective, because there's not reason for us to do it. If we do it, we'll be ringing about something that's quite specific. In terms of the wellbeing service, again, the many thousands of calls that wellbeing service has made, we've been quite clear about, you know, why we've been called in. We can, you know, explain how we've identified that particular person, and we can give feedback to them, which should sort of validate why it is that we're actually calling those people. So that would be the first thing. In terms of mental health services per se and young people, we do have the emotional wellbeing and mental health service within the borough. We do work very closely with schools, so we have things called support time and recovery sort of workers who work and go into schools and actually work and liaise with the schools to provide different sort of programs, education, support teachers, because, you know, mental wellbeing isn't all about necessarily a definite mental health intervention. It can just be about somebody who's needing a bit of advice and guidance in terms of their own well-being and moving towards online support perhaps, or some advice from somebody about particular issues. So our staff are working with the schools, and they will continue to do that. In terms of what schools look like in September, I think, to be fair, it's not entirely clear yet, either from a Redbridge perspective or, of course, nationally. And we will work with whatever the limitations are with us going into the school environment in terms of our presence, because, you know, there are a number of options being contemplated, as people recognise, in terms of year groups being in certain days and certain, you know, certain numbers of people. And so we will need to mould our offer depending on what that environment looks like. It really isn't entirely clear yet. So I'm not seeking to duck your question. The answer to it is we will work with what the schools need us to work with, and we will be as flexible as we need it to be. In terms of through the summer holidays, we're there in the summer holidays. We're not term time service. So if we receive a referral for a young person with a mental health issue or wellbeing issue, we will triage it via our triage hub based at the Grove in Chapel Heath, and we will provide the appropriate responses needed for that particular young person. In regards to people, mental health and homelessness, we now have a street homeless mental health team, which is commissioned for the 4 outer London boroughs. That actually is managed from within Redbridge fortuitously, and I wouldn't say we give any faith or any grace or favour to Redbridge specifically, but we obviously have an interest in making sure our local people are well cared for. During the pandemic, there were initially 125 people who were street homeless, who identified and needed to be accommodated. I believe that number has now gone up to 160 for some strange reason in the last few weeks. I'm not entirely sure about that. As part of the process of the service initially winding down, it's obviously not now because the government have now found additional money to keep people accommodated. We were asked alongside colleagues from various agencies, particularly drug and alcohol agencies, R3, to conduct assessments of people's needs who were potentially going to be street homeless, to see if we can support their mental health needs, and we are working through that now. And we've also been given some additional resource to do that from the council, which is very much appreciated. So that with that, and in terms of people coming out of hospital, it's not really changed because of COVID, because if somebody comes out who's acutely unwell, we should always be preparing an appropriate discharge plan for that person. We would expect to do that. Obviously, we might need to tailor it slightly differently with the needs of COVID. Housing is an issue for this borough, not specifically in relation to mental health cases, but generally, as people know, I'm sure our housing colleagues would give us a few hours if they were here to talk about it. And mental health cases are no different in terms of accessing appropriate accommodation. But again, we have good open lines of dialogue with our housing colleagues, and we will seek to always get people into the appropriate accommodation if they can stand alone, and if they can't, then into supported living if possible.
Okay, look, that's really good. I'm going to call the discussion to a close now. It has been a very full discussion, and as chair, it's going to be quite a titanic task to try and close it down and summarise it. I think my first thought is to say how impressed, obviously, all of us are with the efforts that have been made and the very, very full and detailed information that we've been provided with tonight. So thank you very much to all the contributors, and it's been absolutely excellent. I think it's partly watch this space, isn't it? Because a lot of this, as Dr. Smith said quite rightly, is in flux. We're not quite sure how things are going to work out. It could be a year or two even before we actually arrive at some sort of new steady state. And I think what we as a scrutiny committee need to do is to give some thought as to how we can, within our very limited resources, and time is primarily the very limiting resource we have, how we can set our priorities to, on the one hand, make sure we're scrutinising you properly, but on the other, making sure that we're not making unrealistic demands of you in personal terms. In terms of action, I think that's something which we're having a private meeting later on, and perhaps we can start to address some of those issues in that private meeting. But I think it's going to be an ongoing discussion, and I think one of the key things about this, and I think it's particularly important for outer North East London, not just for Redbridge, but for Barking, Dagenham, Havering as well, is getting a strategic sense of where we're going in 10 years' time. And I'm not going to apologise for repeating it again. I think one of the big issues for the partnership is addressing the huge imbalance of service between inner London and outer London. I could read off the figures, investment, beds per 1,000 population, paediatric services, the whole thing is heavily weighted towards inner London. And my personal view, and I expressed over a very long time, is that that's neither sustainable in service or financial terms. So, and we're not going to be letting that go. How we address it, I think, is something that we need to consider. In terms of specific action, I think thanks on the one hand, and noting the reports that have been made, but I think I'd just like to pick up on that specific point related to Councillor Noor about inclusion in the COVID-19 working group. And although I think we need to have a proper discussion with Councillor Santos about that, I think if it were at all possible, it would be good to see at least one person from this committee included on that working group. And I think Councillor Noor's made the case very well. I mean, nothing could improve communication better than actually having someone from Scrutiny on that working group. It may not be possible for other reasons, but let's see if we can do it, if we possibly can do. Are there any other action points that people would like to pick up on before I close down on this item? No. Okay, so thanks once again, and we'll move on to our next item, which relates to the Health Watch report, which is currently, as I understand it, work in progress. So Kathy Turland is here from Health Watch, covering Vanda, because Vanda obviously has resigned. So Kathy, would you like to tell us a bit about what you've been doing?
Thank you, Chair. It's a quick initial findings of our information gathering survey. So we were very conscious that, and this came up in your last scrutiny meeting, that our concerns that the user voice is not currently being heard, particularly around consultation, because there is a lack of relevant consultation at the moment, and this does need to be addressed. We started our survey, our coronavirus survey, in May, and it's been a relatively slow start, so we haven't been able to get out to our outreach events and engagement in a physical way, which has always been really good for us and has always been responded to appropriately. So far, we've got about 85 completed surveys. They're all online surveys, which again is an issue for us, and I'll talk more about digital in a moment. Our initial response, and this is about our engagement, has been from mainly white females, older females. So that was approximately 70% of the responses had come from older white females, which we are trying to address. And it is really important for us to contact young people and BME communities. So the more help we can have from counsellors, and I know that some counsellors have forwarded our surveys, but we're moving on to how can we gather feedback in a virtual way. So we are starting to talk to community and voluntary organisations to understand if they've got virtual meetings that we can come along to and talk about the issues of coronavirus and the pandemic. We're also getting some training on virtual resources and engaging with people who are digitally excluded. Again, this is a major issue for us, and we're still concerned about that. Initial responses have mentioned electronic media. Some people have really latched on to electronic media. They're using it more, they're making their appointments online, they're having virtual appointments online, and prescriptions, online prescriptions, and the methods, electronic methods for ensuring that they get to pharmacies. Really good. The amount of time that it saved people by being able to have a virtual meeting instead of, as everyone has said here, going to town hall or to a GP practice, it's really saving time on long journeys. So that's been really helpful, and it's great to hear about the uptake of online services. However, we are still concerned because we have no clear figures to know how digital exclusion is affecting some people. We have asked for it. We are part of, and we sit on the pandemic committee as Health Watch, but we have asked for figures because we're getting told how many patients are accessing GP appointments or going online for their services. And we can see that there have been almost 200-fold increase in those appointments being taken up. However, we don't know how many are digitally excluded. Now, I know councillors did mention that older people may be digitally excluded more than younger people. But if you look at the news at the moment with schools, young people are being digitally excluded because they don't have access to websites, Wi-Fi, broadband, laptops to enable them to engage in school activities, for example. However, you can then mention houses of multiple occupation. If you're having a GP appointment and you're sharing those rooms with other people, you can't have a private conversation. So it makes it very difficult. It also makes it difficult for people who may want to have a very private conversation but have people overhearing in their family. So family members overhearing very personal details happening. We have also had concerns raised due to profoundly deaf people using virtual online services and not having the access to BSL interpreters, or a lot of confusion over how that service can be provided, how it can be arranged, and how it is suitable for that person to access. So there's a lot of concerns that have been raised. I won't go into this in detail, I will pick up on what Bob Edwards spoke about with mental health. I do think there is going to be a massive impact very shortly on the mental health of people, members of the public. And I do think we need to address this in some way. The lack of contact and face-to-face contact and support is going to have an impact. And we've seen that throughout the surveys that we have had back. As I said, I'm not going to go through all of this, but I do think this survey will be running until September. The more help we can have from councillors such as yourselves and other statutory organisations to get the message out there, this information will feed into a national Health Watch survey. I think the hashtag is because we all care, and it will be a national campaign that is being launched in July. So it will be actually tomorrow. It is being launched nationally, but I do think this information will feed into the national agenda. I do also feel, I've mentioned that councillors could help us, but we are actively looking for virtual meetings. So if you know of any, or you can let us know, then that would be fantastic. I'll stop there, Chair. I don't think there are any more I can add to the initial findings.
Okay, well, we'll await the report in the autumn with interest, but I have Councillor Islam with her hand up at the moment, so please proceed, Councillor Islam.
Thank you, Kathy. Thank you, Chair, and thank you, Kathy, for your lovely presentation. Kathy, we've got a ward panel meeting coming up on 6th, and I'll send you a separate invite. It's a virtual meeting, and we would have local residents there, and it would be really helpful if you can join us and give us some updates on how to feed back to the national survey.
That would be perfect. Thank you very much, Councillor.
Thank you. We can't hear you, Neil.
You're on mute.
Yeah, no, sorry about that. Trying to cut out the feedback, you know, well. So we'll postpone a substantive discussion until we get the full report in the autumn. I think the sort of responses you're getting are very interesting, but obviously you want a bigger sample size if you can get it, and also one which is essentially more representative than the one you've got. So anything we can do to try and improve that. I mean, I would suggest that if people have any sort of linkages, either through sort of political organisations, doesn't matter if it's a political organisation, people can still fill in the questionnaire. That would be one route that probably most of us could go down, and that might improve the sample size. But anyway, thank you very much for that. And as I say, we'll await with interest. I think unless there's anything else that we have to discuss, Gilly, I'll be closing this meeting and then moving to, well, we've got the work programme, I suppose. Is that right?
Yes, that's right, Chair. And actually, there are no members of the public on the call. Well, actually, apart from the NHS leads, which will have to ask if they could either leave or we can close this meeting down and join the other meeting. But we now bring this meeting to a close as a public meeting, yes.
Okay, so what I'm going to suggest is, it sounds dreadful if I sort of pick out all the NHS people who've been patiently waiting with us, but if you could leave, it would save us having to take the very risky step of signing out of one meeting and then signing into another. I'll probably lose half the committee on the way. So if the NHS people could withdraw from the meeting, thank you again very much for your attendance. We can just proceed with our private meeting, if that would be okay. Dr. Smith, I can see you're still here.
Thank you very much, Councillor. Thank you.
Yeah.
Thank you very much, Councillor. Thank